Welcome. This is Dr. David Nace, Chief Medical Officer with Innovaccer, and I'm very pleased to start this webinar, and thanks for all of you for attending today. A quick question before we get started. I want you to all pay attention to your screen. You'll see that there is a chat box where you can send questions to us, so that will be very helpful. Please send the chat box questions to me throughout the webinar. I'll be able to monitor them, and when we get to the end for questions and answers, we'll get into that. So with that, we'll start our webinar, Changing the DNA of Healthcare in the Age of Automated Intelligence. Really exciting. So with me here today, I have Dr. Stephen Klasko, President and CEO of Thomas Jefferson Health. Before I ask Steve to say hello, I just want to say it's been a thrill to have him as an advisor to Innovaccer. You know, Dr. Klasko has been noted in Becker's this past year as the #2 most influential person in healthcare with a couple others, and being noted as a disruptor. And he certainly has done that over the past 4 years at Jefferson Health. Steve, welcome.
Great, and you know, it used to be that being a disruptor was a bad thing. I think given the tsunami that's hitting healthcare, that's actually pretty entertaining to a lot of folks, and I'm thrilled to be working with you folks at Innovaccer to try to see if we can positively disrupt how data is used.
That's exactly right. That's what we got to do. So, you know, I look back on the past and say, you know, who would have thought? I mean, the world's largest taxi firm doesn't own any cars. I mean, I take Uber or Lyft literally every day. The world's most popular media company doesn't own any content. The world's most valuable retailers don't carry any stock themselves. The world's largest accommodation provider owns no property, and the world's biggest movie house, which we all know and love, owns no movie theaters. Who would have thought? They do this now without walls. So how did this happen? What took these companies to the top to disrupt their industries? Steve, what has been their focus? What's been the secret sauce?
Well, I think they correctly recognized who their customers were. You know, I come from the Steve Jobs view of marketing of don't give people what they want, tell them what they want, then give them what they want. And I think that, you know, if you look at whether it's Uber or Lyft or the streaming companies, it really got down to, hey, this is really something that's different than what you have now.
Yep, that makes sense. You know, I think about what really drove them to be able to do that. And we all know that data has been the key to their success. You know, we all hold our smartphone in our hand and watch the car, the Uber track around the corner. It arrives just in time, and we can see exactly the minute that we're going to arrive where we're going. Incredible use of data in a scalable way. My gosh, I wish we could do that in healthcare. You know, from free 2-day shipping to streaming movies and groceries arriving at your doorsteps, it just makes our life easier and takes the friction out of it. In healthcare, we have to drive and park, take time off work, wait, fill out a form and paper, hand it, have people fax information. It's just a different world. And from, you know, if you look at Netflix, the streaming giant's obsession with customers, knowing each individual customer and how to not only take that friction out, but to make personalized recommendations. Just incredible. And in healthcare, you know, you walk into the doctor's office and they have to remember who you are by asking you questions. So Steve, walk us through this history. Like, how come we haven't been able to do this in healthcare?
Well, look, I think it's a lot of people's fault. And you know, you never go very far blaming your patients, but it's partly their fault. I had made a comment in one of my blogs that got me in a little trouble, but I said patients have way too much respect for their physicians, from the point of view of if you have an 8 o'clock appointment and your doc shows up at 8:45 in the morning, the first reaction from a patient is usually, "Oh, that's okay. I'm sure you had an emergency." And I said, you know, believe it or not, that might be true about 30% of the time. The other 70% of the time, he or she didn't have an emergency, but they just know that it's okay because you'll think that. So I think, look, I think that clearly we're at an inflection point, whether it's the millennial factor or whether it's the concept that we're not going to be using as much other people's money, that people are going to expect a very different level of service. And by the way, this cartoon that's showing, is really true. It's been all about the doctor. And we're moving from a model where the physician administrator is the boss to the patient is the boss. So to use your Uber model, from a business to business model to a business to consumer model. David, I consulted for an OBGYN group, and I'm an OB, and they were going through some of the complaints. And one complaint was that a patient with a paper gown was waiting in the room, cold room, for a half hour for the doc to come in, while he was on the phone that she could hear him making a golf tee time for that weekend.
Oh my gosh.
So the group is getting together and saying, gosh, what are we going to do? Like any consumer thing would be, and their answer was, we ought to move the phone further away from the patients. So the fact is, if we were in a market-driven type mentality, those kind of businesses would be out of business. And I think that the tsunami that's about to come is that clearly patients are going to expect that, as they have higher deductible plans and it's their money. And certainly millennials that have the attention span that's even less than some of us are not going to wait on the line for 11 options to get an appointment next Wednesday, when they can actually do like all their holiday shopping while they're in the pajamas watching Game of Thrones in about 4 minutes and 50 seconds. So I think we're at this huge nexus, and the only question is whether or not we know it or not.
Nope, that makes a lot
of sense. By
the
way, let me just say one other thing. I mean, the simple fact is, to your earlier analyses, taxis knew that people were upset with the kind of service and had played with, gosh, maybe someday we'll have to have apps. And as you know, Blockbuster had the first patents for streaming. Yeah, but you know what? We're going to make a lot more money from late fees. So, someday maybe if we have to do that, we'll do it. And I think that's where we're at healthcare. Yeah, we get it that we're really not consumer friendly, but yeah, at the point that we have to turn on the switch, I hear that a lot, I will. Well, you won't, because by that point, somebody will come in and eat your lunch.
Nope, that makes a lot of sense. Now, you and I have been around a long time. If you go back to thinking about, back in the 1970s, we were all, just to your point, we were talking about fee for service moving to, value, not volume. What was your experience?
That's shown here. I think for such a long time, we just looked at the government and healthcare reform. Yep. And healthcare reform has managed to confuse everybody, right? I mean, but I think what's clear, and for those of you who are on that are healthcare providers, if you want the horror movie part of this, I gave a talk for Standard & Poor's, and they basically talked about whether downgrading the nonprofit healthcare provider sector, because they don't believe we have the data, and they don't believe that we're ready for the changes, and they believe that if we don't make really significant changes in what we do around cost, access, patient experience, and quality, we'll maybe have a 2% revenue increase and a 7% expense increase, and that's not good math. And they recognize that we're going to go from $1.25 of healthcare to $1. And when they talk to pharma, they say, don't worry about us, we'll keep our 35 cents. When they talk to insurers, don't worry about us, we'll keep our 35 cents. When they talk to the PBMs, they say, don't worry about us. They get down, there's only about 6 or 7 cents left, and we say we're going to take care of everybody. So if nothing else comes out of this webinar, I think this is the time where you have to think very differently around cost, patient experience, access, quality, and data.
So everybody hears that, but it's kind of like the Twilight Zone.
Yeah, well, look, yeah, and it really is difficult if you're not that 67-year-old CEO who's going to be leaving in 2 years. All we hear is volume to value. We just got done our population health colloquium at Jefferson, and why haven't things changed? Because in many communities, we're still at 85% volume. And it's great to sort of look at things that have been done in places like Intermountain Health with Mark Harrison. I was just on a panel with him. But frankly, some of those kind of situations like Kaiser and Intermountain are in areas where you can really quickly move to value. When you're in a place like Philadelphia or New York with the competitive providers, insurers, and employers, you really need the data. And the reason that I crossed out bending, I mean, we have to smash the curve. We really do. And I think, and we have to stop, having academic exercises around population health. How can we take care of a population health, or a population in a fundamentally different way? Do we have the data? How do we start to look at the social determinants of health? And I think, David, one of the things we least talk about is what I call consumer segmentation. The concept of we're so excited that we're patient centric. Like there's one patient out there. If you talk to Amazon, which I have, they have 1,187,285 categories of customers. And within each of those, they have subtext. So we are just at 1.0, but we've divided our customers into 6 segments. And what's interesting, it's not necessarily age, right? Because there could be a 65-year-old person with 3 Fitbits, that literally how you communicate with them and how you get them engaged is going to be very different than a 23-year-old disengaged person. But how you're going to get them to be part of your club so that when they do get sick, they're coming to your hospital are all very different. So we have to think about patients as consumers. We're over that fight. Nobody thinks of themselves as a patient. Nobody wakes up in the morning and thinks of themselves as a patient. We also have to get away from just talking and being excited about the technology, right? My good friend John Scully is going to be our commencement speaker, and he says, Steve, stop talking about telehealth. He goes, we don't talk about telebanking. We don't get up in the morning and say, no, I think I'll telebank today. It's just that 90% of banking has gone from really being a pain in the neck in a bank, if you're my age, before 4 p.m., to really 90% being at home where you're frustrated if you can't deposit a check at 5:30 in the morning. That's where we're going to head. The only question is how long and who are going to be the leaders and who are going to be the ones that aren't in business anymore because they couldn't figure it out.
Yeah, I think about what we were talking about before with, folks like Netflix and Uber and how they personalize and understand your behavior, track everything that you do. And we've gone to talking about moving from fee for service, the population health, by basically stratifying to 3 or 6 categories, like who are the 20% that are the sickest, and then there's the medium that have some emerging illness, and then there's the, well population. But we really need to get personalized. I mean, we need to get down to the level of tracking and understanding each patient, move from provider-centric to truly patient, not just category-centric.
Yeah, so, and I think when you move from a business to business to a business to consumer model, then you really start to fundamentally recognize, I think we've done a good job in the old way of segmenting our doctors as consumers. I know that the cardiologists need this, the neurosurgeons need this. So we got used to that because they were our customers.
Right.
Now the patients are going to be our customers, and even the way we market, David, is sort of a joke. I mean, you can't be on Morning Joe in my area or CNN or any of those without a 30-second commercial from any of the cancer centers here, literally that their head's down, they've been diagnosed with cancer, they walk into the cancer center, they walk out and they're frolicking in the weeds and they're happy. Nobody that's a cancer patient really believes that that's the answer. And as my growth team says, nobody that, God forbid, is diagnosed with pancreatic cancer drives up or down our highway and sees who has the coolest billboard. So starting to look at how you can bring data together and, again, segment consumers to actually start to market to individual people and groups of people is really going to be the key.
Yeah, and you and I were just talking about, before we got on this webinar, this issue around, Innovaccer, we activate the data. We, our colleague, David Nash, I was sat in his office a year ago, and he said, David talking to me says, I am tired of being swamped in bar graphs and dashboards. I just want to know what to do, like the next step when a patient's in front of me. And I think about how these industries have activated the data to really be successful. You and I were talking about Domino's and how they've activated their data around marketing and delivery and understanding the consumer and taking the friction out of care. You want to say a little bit about that? Because it's been a phenomenal history for them once they started activating.
Yeah, I was telling you, you actually could have put Apple's stock price, because everybody uses that. Boy, if I just bought Apple at 15, 27 splits ago. But Domino's actually would have been a slightly better stock, and we don't talk about that. But yeah, look, what they did that was absolutely brilliant is they looked at who's actually buying their pizzas and what's going to get. Let's face it. None of these pizzas are the pizzas you're going to get in Milan, Italy. Okay, so the fact is, it really got down for millennials. It was all about like, hey, I just got done a fraternity party, or maybe consuming some illegal stuff, and I really would like I would really like a pizza. I just want it now. And so they not only basically created the app that made it incredibly easy they were the first ones that your pizza's being baked, your pizza's being this, but they also, for that group of people, were on YouTube literally almost mirroring, like the first Bueller's Day Off. Then they looked at people, my age, that might be thinking more about fresh ingredients, and they marketed around the fresh ingredients and that kind of thing. So they were able to beat Papa John's at their own game. So I think it's a great example of what you can do. I don't know how many segments that they did it, but they basically made sure that the people that were going to use their iPhone to order, it was the easiest. The people that were going to use the computers to order, people that were going to use the phone to order, that literally the people that answered the phone immediately got a screen up there if I'm actually calling on the phone and not using the app. Hi, Steve, how are you doing? I saw last time you ordered a pepperoni. Do you want the same one? By the way, you're a frequent flyer, so here's $1 off, and as opposed to the app. It's really a brilliant strategy. And when you think about it, that's what we need to do. There's some people that want to have almost all their care telehealth. Interestingly, we were just at a conference, we were talking about telepsych, and people under 40 that are thinking of talking to a psychiatrist or a relationship person would much rather talk to a bot than a person. They feel less inhibited talking to a bot.
That's right.
So not like it's even equal. Yeah. So I think we have to start thinking differently.
Yeah, no, those are great points. Hey, it sounds like data is so key to all of this. I'd like to turn it back to our audience and see, let's see what's going on with them in terms of their use of technology and data. So we have a poll. We asked for each of you to go ahead, and we're going to surface this poll. A couple questions. What phase is your current organization, your health system, your payer, in terms of implementing technology in a useful way? You feel you're an expert? You've implemented the right technology and you're activating your data? Do you feel you're kind of in the middle, you have the right technology, but you haven't quite activated the data? You're still looking at dashboards and graphs and data visualization and trying to figure out what to do with it all? Or are you a beginner? Are you starting to figure out what technology do we need and how do we start gathering the right data? Because it's in all different sources. Or are you, like many of us, that are sitting out there, in rural areas and places that haven't adopted technology, that they're a little bit scared about their data because it's quite a mess? Or is, Steve, you'll love this while we're taking the poll. I was down in Atlanta at one of the leading hospitals, and they told me, we don't have a data lake, we have a data swamp.
Well, yeah, and honestly, that's people say the problem's data. The problem's not data. We are up to our patoot in data. The problem is what you do with the data and then defining how that's going to change what you do, right? I mean, it's a little bit like quality. I remember when we were at the JP Morgan, Bernard Tyson said, I'd like to congratulate the 600 organizations that are top 50 quality places, because depending on what your parameters are, you can be top 50 or bottom 50 in the same organization.
So we're just taking the poll here and trying to wait for the results. And really curious where we're at. We're at about 60% voted, so we'll go ahead and show the results. And here they are. Now, not many people are feeling that they've activated their data yet, and a lot of people are starting to adopt technology and not use it. Steve, what do you think of these results based on your experiences?
Well, listen, I think that's really right. I think everybody has recognized that they've got data. Look, even look at population health. Predictive analytics. We've had 6 different groups in. We have an ACO that has one. Since we've had so many mergers, every one of our places, just like EMRs, had different data repositories. None were really happy with it because they really, the whole idea of data, the only thing that makes sense, whether that's AI or predictive analytics, is okay, I can look at this on a daily basis and it's going to change my behavior. It's a little bit like, frankly, why some of the Apple Watch and Fitbits on the consumer side haven't really caught on quite as well, because you can count your steps and you can do all this stuff until you start to take things like on the consumer side, wearables, and then attach it to your Alexa. So when you wake up, it says, boy, you have asthma based on your respiratory rate and the AQI, you're going to need an extra inhaler. That's when people go, aha. As soon as I can partner with a company like yours or other companies that take all my data from all my systems and say, you know, Steve, in your neuro group, if you did these 2 or 3 things, you would decrease cost and increase quality, then you would start to get into that expert piece. So I think we're just starting to get the data. I think the last thing that we haven't talked about yet is it's harder to do in a situation like most of us are in, where we don't have a strategically aligned payer partner. Because in a place like ours, where we have you know 5 or 6 different insurers, where we're really seeing some wows in data is for our 30,000 employees, because that we have one insurer, we're self-insured, we're at risk. Both the insurer and I are in the same place wanting to do that, and they're willing to share all the data. So we're seeing what it could be. It's actually a good teaser.
So we're talking a lot about, you know, this impending change in healthcare that we all feel or palpate that's just around the corner. So as we look at this, how are we going to survive this disruption? Like, what are the key things that we need to do to sort of get beyond that?
Well, look, I think, you know, I think first of all, we have to look at how we pay folks. And I think the second thing is we don't spend enough time talking about the human aspect of this. I mean, if you think about it, almost every doctor in your system came up through that fee for service thing, that if I do more, many of the people that are listening to this webinar, many of your incentive systems are still RVU based. And you know, there's a great Upton Sinclair quote: it's hard to get somebody to do something when their salary depends upon them not doing it. We do that a lot in healthcare. So just real quickly, I think one of the things that you have to do is you really have to put dollars and real effort into creating a leadership academy around this disruption. And you also have to figure out who to go after. Just we looked at it and said 20% of our docs get it, 15% will never get it, and there's 65% in the middle. We found we spend a lot of time with our docs that get it, a lot of our time with the docs that don't get it, and the minimum time with folks in the middle. So what we do now is, with something called JOLT, Jefferson Onboarding and Leadership Transformation, we literally turn the docs that get it into mentors. We ignore the folks that will never get it. We call that administrative hospice, David. We just let them sort of be comfortable and go away. And then we concentrate on the 65% in the middle. We've done that for 4 years, and it's really created more of an aha type moment where we have more and more families saying, oh, now I get what's going on. So this is why I have to look at things differently. And then I think you just have to titrate for the next couple of years that volume to value. I'll give you like one really good example. We invested significantly in telehealth for unscheduled care, where we have 24/7 ER doctors. We believe that we get 65% of our unscheduled care, based on the data we have today, out of our expensive, inefficient EDs. And we have almost 700,000 ED visits. So all right, that's great. We would have lost our shirt on our current insurance contracts because we average about $1,500 per patient in the ED, and I get $49 on a telehealth visit. So with our 30,000 employees and our insurance partner, we said, let's see if that works. And we have a model now. If one of our employees comes into our ED in a non-trauma, non-ambulance type situation, and she hasn't gone through Jeff Connect, it's $1,000 deductible. If they've gone through Jeff Connect, it's a $0 deductible, because there's a 70% chance we can take care of them in urgent care or on telehealth or with an appointment the next morning. It's been a wow. We partnered with companies like Ovongo to do the same kind of thing. So we know we can do it. So, you know, we feel good that if tomorrow we had to turn on the keys of value, we're starting to get that skill set and starting to partner with companies like yours, that we can start to turn that data into something that could turn the switch on and be ready for that value.
So it sounds like, you know, we all talk about, geez, we just need to change the payment model to more risk-based, But what I'm hearing is you need to go out and take risk in doing things you haven't done before and move beyond traditional healthcare. And that part of that is looking for partners, technology partners, payer partners, and then doing things that nobody's ever done before, like telehealth and telemonitoring and putting kiosks in the community. So you really need to take risks. When you think and talk about the Netflix model of healthcare and building healthcare that has no address, what does that mean?
Yeah, so for us, that became sort of our moniker of that instead of talking about telehealth or whatever it said, Jefferson's model is going to be healthcare with no address. Getting literally folks to consume their healthcare the way they consume everybody else. The simple answer to what does it mean is that if 5 years from now, David, you've never been in Philadelphia and you come here and you say, "Where's Jefferson?" I hope people cannot answer that question. I hope people say, "What do you mean Jefferson?" Jefferson on my phone, on my TV, with our partnership in Italy, the model where we can get all of our care in one of their 19 urgent care centers or 6 micro hospitals. Oh, you mean the place where really, really, really sick people go to get transplants? I think that's still a 10th and Walnut. And when you think about how that fits in with the Netflix model, nobody knows where Netflix is headquartered. I mean, if you said, "Where's Netflix?" I don't know where Netflix is. What I know about Netflix back in the day was that, little red thing that I would get in the mail with the DVDs and then the Blu-rays. And what I know it is now is that, if I want a mind-numbing experience, I can, go on my Apple TV and put Netflix on and, watch what Michael Jackson did wrong, or, watch the latest series, or watch Game of Thrones or whatever. So to me, they've become a subscription model, an aggregator, a platform, as opposed to it being about the medium. And I think that that's what we have to get to. Again, what I think we want to do at Jefferson, I want people from the time they're 35 say, "I want to be in the Jefferson Club. I'm not sick, but I want to be in the Jefferson Club," so that, if and when they do get sick, there's no question where they would go for care.
That's right. So if we're going to have a consumer model, then the consumers have to make a choice to be a member. So how do you think about that shift from the wholesale to the retail model?
Well, look, I think we talk about it this way. We're working toward an obsession around making what's difficult in healthcare easier, is probably the best way to put it. So what we've started to look at is, what are the things that make it difficult for people to do it? So yes, certainly enterprise internet scheduling. We're partnering with a company that's providing transportation, not in an Uber Lyft way, but literally in a health way. So if you need oxygen, they'll provide that. But literally, what's making it seamless, not that we'll give you 10% off if you call Uber. When you schedule an appointment through the internet or through your phone at Jefferson, there will be a little box that says, "Would you like our transportation option?" With some AI and with the patient's approval, they'll know enough about you to say, "All right, you need our car with oxygen and an EMT, or you need our car with just oxygen, or you just need a car." It's tied into our Epic. So at the moment that they're done their appointment, just like, after you get out of Uber, you get a little text, "Here's the thing." But the moment they're done, they'll know they're done, to say, "We're waiting outside of the Gibbon building waiting for you." And we're even working out with them a potential way of, if the doctor's behind, they'd be able to know that and say, "Look, you have a 2:30 appointment. I was going to pick you up at 2, but the doctor's running about a half hour behind, so I'm going to pick you up at 2:20, so you don't have to wait." Literally, that is enough of a differentiator that we believe, especially again when we get to some of those younger patients, that what we used to compete on, U.S. News and World Report and that kind of thing, people will say, "Wow, I want to go to Jefferson because that's just so different than what the competition is offering." I mean, by the way, that's assuming you provide great care. I think what we have to recognize is what Standard & Poor's would say: great care is going to be somewhat of a commodity. I mean, if you look at Philadelphia, we have 5 academic medical centers. They all provide great care. I'd like to think we provide the best care in caring. I'm sure Penn feels the same way, and Temple and Drexel and Cooper. But at the end of the day, if you need a knee replacement or you need bariatric surgery, and you go to any of those 5 places, you're going to get great care. So then how do you differentiate yourself?
Yeah, and I like what you said about care and caring, and we're going to get into that in a little bit, not quite yet, but that caring part is a key piece of it. But I think what you're saying is there's a lot of assumptions you have to make in terms of, cost, quality, hospital stays. Can you walk us through some of those assumptions, and particularly assumptions in terms of how to move forward?
Yeah, look, I think great organizations say so. I had a chance to be on a committee working with Apple, and you know, it really, David, was my aha moment because I recognized that what Steve Jobs and folks like John Couch did was they were always looking at what was going to be obvious 10 years from now and say, let's start doing it today. And the genius of literally recognizing that their industry was going through a once in a lifetime change from a computer industry to a digital lifestyle um, was putting out that iPod. They were still making computers. So that's how I look at it. When I talk to my team, I say, look, we have to do a great job at taking care of all the people coming to our hospital, and that's today. But let's recognize that the assumptions that I'm working on is that we'll be paid based on quality, cost, patient experience, and outcomes, not RVUs. That our hospital stays themselves will be commoditized. There will be micro hospitals, there'll be other things. That our doctors and nurses will coexist or cooperate with deep learning, machine cognition entities. That the humans need to be different. That Jack Ma had a great quote at the World Economic Forum. He said, when we created cars, we didn't try to get humans to run faster. When we created planes, we didn't try to get humans to fly. Computers will always be smarter than doctors, I'll paraphrase, but they'll never be as wise. So how do we start to create doctors and nurses that are more self-aware and empathetic as opposed to great memorizers? And then there's no question that population health, predictive analytics, and social determinants are going to be important. We have to start look at how we teach them. We have to have people, for example, if they're going to use entities like Innovaccer and other AI and predictive health analytics, that know a little bit about the coding and the engineering, and it's not foreign to them at the point that they get out of my medical school or residency.
I really like that you talk about this technology and how to work with people and how to think about the new technologies. One of the things I've noticed is everybody says artificial intelligence, but when I talk with you, you've talked about augmented intelligence, and it really fits into some of what you were just saying. Can you tell us a little bit about how you think about that term as opposed to artificial intelligence?
Yeah, look, there is no artificial intelligence. I mean, the simple fact is, Kai-Fu Lee calls it OMO, online meaning offline. So the whole question of your wearable, your phone, your Alexa working together with your physical being is where augmented intelligence will help. And it's been very hard for me to sort of communicate this to my doctor colleagues because if I go out there and I'll say it today, and you'll probably get some comments that technology will replace 80% of what doctors do. It's like, oh, how dare you say that? Well, it will. But then the other thing I'd say is that any doctor that can be replaced by a computer should be. So the fact is we're always going to be needed for our humanness, for our self-awareness, for our empathy, for our being able to read between the lines. For us to think that we're going to be smarter than an augmented intelligence robot, and I'm an obstetrician, at taking a picture of that baby, going through its database of 28 billion pictures, and then saying, this is what I think is chromosomally wrong. Oh yeah, well, I got an A in organic chemistry. We're going to lose that fight, just like we're going to lose every AI fight when it comes to chess or whatever. So I think the key is coming to a realization that there will definitely be a robot next to me, and that it'll be important to me for me to be the human in the room. It'll be important for he, she, or it to be the robot in the room, and that we'll have to work together. And to me, that's a very, very, very exciting thing for me that I think will start to make the difference. By the way, we're looking at partnering with some of the AI teams around some of the social determinants, because just like that consumer segmentation, it's easy for us to say, the problem with social determinants is food, education, and housing. Great. So what does that mean? Well, if you actually get augmented intelligence to social agencies, you'll find out that the problem in the Latino population in Northeast Philadelphia is different than the problem in the African American population, and what you might need to do. So I'll give you a real life example. We had one of the highest rates of premature labor of any place in the country among a Latino population, one of the places that we worked. And everybody was trying all these different technical things. Well, it turned out that when we actually started talking to the patients, that they didn't like to go to the hospital if they had a normal obstetric thing because they looked at the hospital as being sick. So what we did was we deputized lay people to measure the fundus and listen to the heartbeat, and did it at a Hispanic sort of social place. And we made a deal with them every 3 months to come in to the office. We were able to get within 6 months the premature labor rate down, below the Caucasian mean. At Jefferson, we're doing something called hotspotting, where literally nursing students and medical students are actually talking to that 5% of patients that uses 50% of resources, and then again partnering with the data and the augmented intelligence. But it took that human piece to actually get the patients to change their behavior.
No, that makes a lot of sense. And you really covered a lot of topics here about the use of technology. I mean, we all use our phones. I see people walking around. I can't even answer questions about people I know, or it's my augmented brain and it's my augmented transportation system, and it works with me and I work with it. And that's really the key, is having that anywhere I go, right? That access, that experience, and that convenience.
Right. I mean, I think you can almost look at any other industry, and we will get there. I know that everybody says healthcare is different, but we're looking at a model for a match.com between obstetric patients and obstetricians. Why? Because most obstetric patients are young, and the chances that a 25-year-old woman, where it used to be, David, is I'm an obstetrician, so they'd go to their 65-year-old male primary care doc and say, well, congratulations, Mrs. Jones, you're pregnant. I'm going to send you to my obstetrician, Dr. Klasko. There's zero chance a 26-year-old woman is going to say, oh, great, that's who I'm going to go to for the most important thing in my life. She's going to get on her iPhone and start to look at what different people have said. So we've actually created almost a progressive insurance or match.com between those folks of what do you really want? I want somebody that will accept my doula. I want somebody that's get this. I want them to share their data. And we think that's the kind of thing that people will expect.
And that's really moving to the Netflix model. It's personalized, it's just in time, it's exactly what they need, and they can feel that. And it takes the friction out of healthcare. What really strikes me, though, is as we have all these smartwatches and anxiety detectors and wearables and home, like we'll have Alexa in the home collecting data all the time and information, helping you to personalize that information. But we're going to learn more about diseases when we have this 24/7 collection of information than we ever knew before.
Yeah, and look, I think that I made a statement at the World Economic Forum. I said, they said, what do you hope that a couple years from now will be different about the panels in the World Economic Forum? I said, I hope we're talking less about self-driving cars and more around self-healing humans.
So let's talk a little bit about this. You've done some great, moves at putting, kiosks in the community and really focusing on having you based, as you mentioned, care and caring. It's not about just technology, right? We need the doctors too. It's both sides of that coin. Like, as an academic medical center, like, how do you think about the needs for pulling these two things together?
I think it's simple. If you believe in that future, then you start to say we have to stop choosing doctors based on science, GPA, MedCats, and organic chemistry grades solely, and then be amazed that doctors aren't more empathetic, communicative, and creative. Right? I mean, duh. So, at Jefferson, we look at holistic criteria, and we have literally, we not only select doctors differently, but we have a whole humanities curriculum. And one of the most successful things has been we take third-year students that are going through clinical clerkships. We partner with a local theater agency. We take the most emotional things positively or negatively, and they create little 5-minute vignettes or almost like plays around that experience. That's been incredible for them, sort of cementing that human piece of what we do. And then again, I think what we need to do is have folks like Innovaccer folks or the folks out in Silicon Valley actually embedded into our training, so they're understanding the augmented intelligence and data piece of it. And then frankly, we should have doctors and medical students out at your labs with your engineers so they understand what the humans have to do. We really need to get to the, it took us 30 years, David, to get doctors and nurses to work together. And we're so proud of ourselves that we now have some interprofessional education. Now we're going to put robots in the mix. And I think that that's going to be a whole nother, like pretty soon you're going to have like intersentient education. This robot really got me upset type stuff.
Yeah, it's fascinating. At Innovacers, we talk about activating the data, which what we mean by that is having the data become insights in terms of what to do when you need to know it for all the players in the ecosystem, right? The doctors, the care managers, the pharmacist, even the patient's caregiver in the community, the person they decide, their husband, their spouse, to bring into the fold. Everybody receiving an insight when they need to know it and coordinated and working together through the technology provided with some augmented intelligence. So we have digitalized healthcare, we had the HITECH Act, we rolled it out, and let's ask our audience kind of what their experience with technology is in their doctors. Are you really getting the value we're describing as where we need to be from your current technology? So, what troubles your doctors mostly in their daily work? To be able to be creative, to be compassionate, to be empathetic? Is it the limited availability at the right time about the specific patient? Is it the unnecessary administrative activities that take up much of your time as a physician? Is it the pecking around in the computer? Is it filling out forms? Or is it limited resources in order to interact with the patient, particularly not just when they come in the office, but also when they're in the community? Being able to reach them when you need to reach them or when they need to be reached or them to reach you? Or is it these clunky, complicated, transaction-oriented systems that have been hindering doctors to be more focused on pecking away at their computer? While we're running this poll, Steve, my father, who passed away about a year ago, he used to tell me, my doctor doesn't talk to me anymore. And I would say, why is that? He said, well, his back's turned to me and he's not talking. I said, well, why is his back turned to you? He said he's too busy on the computer to spend any time with me when I'm visiting.
Yeah, look, I think that's right. In fact, we got a question that really hits that from a mid-sized behavioral health provider that basically our EHR system is moving like a turtle and helping us get more meaningful data out of our EHR system. So look, EHRs are exactly what we don't want to have happen in the next generation of AI. And when I say that, it's the only new technology that's forced you to add more humans to the equation, right? If you think about new technology, what it does is you should be able to do a better job with less humans. And here, the EMRs are basically, now I have every one of my doctors saying, now I need a scribe so I can get back to where I was before and being able to talk to patients so my back isn't to them. So the simple fact is we have to do a much better job at that. And it was partly because we weren't really involved in the genesis of the MRs. It was made over in some engineering lab, and then we had to do them, but they were never really meant to be a doctor or a patient-centric type model. I'm hoping, and by the way, telehealth has gone down the same thing. It's big companies saying, I want to, really create IPOs, but it was, this is what we want to create. I'm hoping, and that's why I like to work with companies like you and some of the other folks we're working with in Silicon Valley, is, I want to be involved in what you're creating, and I'm willing to open up Jefferson to you so you can see what we really need. So when you actually do your product, it's actually what my patients and my doctors and I need.
Yep, that makes a lot of sense. So why don't we open up the poll? We've got a majority of people responding already and see where people are at. Well, here we are. Interesting. Big humps on unnecessary administrative activities and complicated systems. Steve, what do you think about this?
Yeah, well, look, I mean, we did a talk with Jonathan Bush and I did a talk at South by Southwest last year for around physician burnout. It's the least talked about part of physician burnout. Physician burnout is because doctors don't feel they're, quote, capable of being able to do the things that they went to medical school for. And when you ask them why, their number one thing is things like EMRs and unnecessary administrative activities. So that what we hoped would actually help them do more with their patients has been the biggest cause of burnout. So the next generation of AI, whether it's Innovaccer or any company, has to be something that gets doctors to feel more capable to do what we like to do, which is interact in patients, have the data we need exactly at the time we need it, so that I can do a better job hands-on. And I like what 43% of people say is it's too complicated, it's unnecessary administrative, it's basically negatively helping me. Yeah, it might not have been as good when I was talking to a pregnant patient because you couldn't have read my handwriting, but I was looking in her eyes and I was writing it down and I could read my handwriting and I got into a rhythm. Now, literally, I might as well not even be there because I have to type everything on a template in the corner of the room, and the scribe is actually, sitting next to the patient.
No, it's fascinating. I know here at Innovaccer, when we work with our first client, they used our physician point of care solution, which regardless of what EHR they're using, it would slide in from the right, see who they're working on, give them insights across all of the data sources possible. Who else is writing prescriptions on a different EHR? What care gaps does the Medicare Advantage plan they're enrolled in need to be closed in order to get better incentives? The patient was in the ER 5 times in the past 2 weeks. They haven't told me that. Why not? Well, it's right there in front of you. You don't have to hunt and peck. They were able to save 3 minutes per doctor's office visit because the doctor was less encumbered by that time. And they said that doctors suddenly felt like they were practicing medicine again. In fact, the nurses and the physician assistants would feel that way too. So there is promise in technology. It's not always going to be complicated as it has been. So let's talk a little bit about, you've mentioned patients need to be active in their care journey, more engaged with, and they can be that way with technology, with their care team. That the technology people need to focus less, complicated systems, and that you need to start working with payers in your environment. What is this concept that you've had at Jefferson about the patient diamond? The patient
diamond. I think the iron triangle, frankly, is pretty 90s. Yes, we have to decrease costs. Yes, we have to increase access. Yes, we have to increase quality. And yes, we should have a better patient experience. And that's like pretty boring. And by the way, if I was anybody in another industry, I'd say, yeah, like that's what you should have done 20 years ago. Patients don't view it that way. They just assume that that's right. It's like saying, wow, I'm going to be the coolest transportation department. Your roads will be smooth. Yeah, I shouldn't have potholes. So what patients, the patient diamond of healthcare, I believe that they're going to look at is my ability to thrive and not have health get in the way. Because I don't want to think of myself as a patient. I want to think of myself as a person, and you're going to help me stay healthy. The ability to connect and have human relationships. Because when I want to talk to a robot, I want to talk to a robot. When I want to talk to a human, I want to talk to a human. The ability to easily navigate on their own terms, however they navigate, that gets to the consumer segmentation. And we talk about transparency. Transparency in 2019 is a joke. Transparency is saying, put all your charges out there. So people put out 287-page charge master things, that make your brain want to explode. When patients don't talk about transparency, they talk about the ability to understand what they need to do and how much it'll cost. Understand it. So in these Medicare expansion states, a lot of times you get this 56-page thing, and they think it's great because it's in 4 different languages. But I'm an MD, MBA, and I don't understand exactly what to do. And you think about how Netflix or getting a new Apple product, the AirPods that just came out, not that I'm advertising for Apple, but the new AirPods, you open them up, your iPhone immediately says, oh, you have new AirPods. You press here, your AirPods are on. That's what patients want.
So you wrote a book about where we're at today and comparing it and trying to jolt people into thinking about what that means in terms of reality, and just think about it can't continue this way.
Yeah, and it is a parody. It's Bless This Mess, a picture story of healthcare in America. It's written with a very, very talented illustrator. I did put a warning, this is not a children's story. And don't read at bedtime. But the concept was that we got admitted into in 10 or 15 years from now into the Intergalactic Council of really awesome healthcare systems, and they were amazed because they came back in 2019 and they remembered how messed up we were. So what did we do from 2019 to 2029, and what we learned from about 9 or 10 other planets. Yes, it's clearly a parody, but it's also a pretty stinging rebuke of those of us in the healthcare ecosystem.
So, I don't know that I'm going to be around when we join the intergalactic galaxy of healthcare providers, but I do know I should be around in 2018 when things are much better. So, if you think about us in 2028, looking back to 2018, saying, how did we get there, right? So, what are the things that we were doing that was stupid, and what are the things that we did that was right?
Yeah, so I think the first thing that'll happen is I think some insurers, some healthcare providers, some pharma, and others some need to fail. The ones that haven't figured out. In every other market, that's what's changed things. So that's the first thing that has to happen. I think the second thing that has to happen is we have to start to aggregate some of these technologies. David, I walk into HIMSS. There's 972 booths. I get accosted by 24-year-old that gives me a Hershey kiss and say he's transforming healthcare. And okay, tell me what it is. Well, I've got this revenue cycle app. Or I walk out of conferences I give and I feel like Bon Jovi because 100 people are coming to me and telling me how they're going to transform healthcare. So we've got to bring some of this technology together in a way that's really, really making a difference. And then finally, I think we need some strategic alignment around payers and providers in a different way that we're all competing against everybody. I think some of these vertical partnerships like CVS and Aetna and Humana, either Walmart or Walgreens, will start to provide some of that.
Yeah, we've been getting a lot of questions from our audience, and I think, a lot of folks are saying, like, as we move into our question session, and it's just been great questions that we're getting in here. People are saying, geez, I'm in a rural hospital health system. I'm hearing that, this, value-based contracting is coming. CMS is saying they're going to end fee for service. What are the things that I need to start thinking about?
Oh, look, I think there's a couple of things I'd say. Each of our health systems has different things. I'm in an urban, obviously a very urban environment, but we've started actually to partner with Mission Health, which is in a very rural environment. And I think so. One thing is the things like telehealth. You could argue have exactly the same problems. We have the greatest discrepancy in life expectancy between people in my zip code and 6.2 miles away. That's no different than the fact people in rural North Carolina versus Durham or Raleigh. So I think we share that. I also think that we have to start looking at how we can partner with companies like yours and others, and how we can actually work together to develop the product. I think one of the questions that got asked, which is a really good question, which I don't have all the answers to, maybe you do, but it was, until patients are required to be personally responsible to carry out what we physicians require: diet, exercise, stop smoking, lose weight, will we always be fighting with socially independent factors to drive healthcare advancements with AI? And that's a great question. I think the whole issue of patient responsibility is a big one. I'd like to see what happens once we give them easy data and data that their Alexa can do. I happen to be of the group that thinks that most patients, never 100%, but 80 or 85%, if they had data of how they could stay healthy and do it easily and quickly, that they would want to be healthy. You'll always have that 15% to say, I don't care. I mean, just like you're going to have a very small percentage of people that do harm to themselves. But I think part of it is they don't really know what it is to be healthy. And we haven't done a good job of explaining to them the benefits of being healthy. It's always, you're too fat, you smoke too much, and it's always negative. And the last piece of that, we've done a really lousy job of putting behavioral health into this, because behavioral health and motivation is a big part of social determinants. So as you know, there's some really good AI companies being formed where patients can start to understand through digital footprinting and other means, how they're feeling about things.
Yeah, absolutely. And I think, there's been a lot of opportunity for partnerships here. Steve, I actually want to thank you for reviewing our paper that we published about our methodology for including the social determinant of health information down to the level of a zip code, and then forward predicting models to at the individual level, looking at personalizing the interaction you need to do as a health system and a community. So health systems need to start figuring out, like, with their population, where are the specific areas that they need help in the community, and how do you partner with them? And then how do you individually look at people's behavioral profile to figure out the best ways to connect them in the community and others to deal with these issues: diet, exercise, stopping smoking, losing weight. I don't think the traditional fee-for-service physician office is going to get anywhere with that.
I think that was a groundbreaking article because it really started to look at how AI and data can start to get down to a community and social determinants level. But here's what I'd say: this is solvable. I mean, you look at food. The reason that there were food deserts before is because, if you were in a certain zip code, I have like 3 Whole Foods and Trader Joe's that they're easy for me to get to. If you were in a certain zip code, the only place you could walk to or bike to was a bodega with Fritos and Cokes. And now with delivery services and that kind of thing, if I was running the world, I would have a situation where if you're on food stamps or electronic food transfers, that if you agree to healthy food, that we'll give you 1.5 times what you were getting before, and then do a partnership with Amazon or whatever that may be for free for those people. They would get the delivery service. In my hospital today, you can say, boy, why are your employees eating unhealthily? Because every vending machine we had, David, was Fritos, Tasty Cakes, and all good Philadelphia companies, and sodas. We replaced them with something called Simply Good jars, which are basically, if you want to go to a vending machine for lunch, it's quinoa, it's soups, it's really healthy stuff with all the nutritional stuff. So some of that is stop blaming the patient, make it easier to eat healthy than to eat unhealthy.
No, that makes a lot of sense. And the questions have just been pouring in, and it's really exciting to see such engagement. We are entering into the bottom of the hour here, so I just want to sort of wrap it up. First of all, I want to thank you for all the help that you've been, not only to us at Innovaccer, but for in this webinar. We've had a good 300 people attend. They've been listening, they've been engaged, and they got to get back to work. I think if you could give them one last quick insight in terms of what they need to think about going back to their work to really make a difference.
So I would say just 2 quick things. One is, now is the time. I use this quote, David, you've heard me say it before. Jason Kidd, when he went to Dallas Mavericks, said, we're going to turn this team around 360 degrees. Like we do a lot of that in healthcare. With technology, we end up in the same place. But the second thing I said, and it's actually consistent with a question we got, which is, all of our providers on different EMRs, it makes it even more frustrating. We have to look at how we can create fire layers, HL7 layers on top of the legacy EMRs that literally make them sort of the dependent variable. So we can create a marketplace, an app store. When I used to use Macs back in the day, I couldn't do PowerPoint because Steve Jobs didn't want any Microsoft products on the Apple, and vice versa. Well, that's unsustainable. We're in an unsustainable situation now where if you're Epic, you can only use Epic apps. If you're Cerner, you can only use Cerner apps. That can't be. And once you open that up through interoperability and some of the new fire layers, the HL7 layers, some of the things that you're doing, some of the things that we're partnering with, that's going to start to really have the legacy EMR be less important as far as your ability to cross hospitals and insurers and physicians.
That's exactly right, and that's exactly our vision here at Innovaccer, create the iOS for healthcare. Steve, thank you so much. That concludes our webinar, folks. We thank you deeply at our heart. Let's all go make a difference, and that concludes our webinar. Thanks, everybody. Take care.